Welcome to Mental Health Disorders. Today we're going to talk about the concept of sanity and what mental health disorders are and some of the major consequences of dealing with them. So before we get into the meat and potatoes, let's talk about some of the terminology that we need to know. Psychopathology means the psychology of the mind. So if you think about it in terms of the symptoms and signs of mental disorders, including a depressed mood, panic attacks, bizarre beliefs. Things like, for example, your bones are melting inside of you, which is a fairly common belief. Then the next term is abnormal psychology, which is the application of psychological science to the study of mental disorders. And we're going to discuss this in detail later on in this PowerPoint. Psychosis is the term that refers to mental disorders in which the person is considered to be out of contact with reality. This is often the term that's applied when people are schizophrenic and they're hallucinating or they have delusions. So, for example, when somebody believes that they are a minion of Satan or that they are an archangel, they would be considered to be psychotic or experiencing psychosis. The word insanity is often tossed around. That is not a medical term. In fact, it is a legal term, which refers to a judgment that a person can or cannot be held accountable for criminal behavior. So if somebody is psychotic and they believe that they are acting on behalf of Satan or God or the CIA or some other group that they have no affiliation with, but they believe they do, and they commit a crime, that group disavows any relationship with them, or God is like, yep, nope, don't know this guy at all. This person is not held accountable. One of the most famous cases of this is John Hinckley, who tried to kill President Reagan to impress the actress Jodie Foster. He was not considered guilty of attempted murder, but rather found to be insane. And he was recently released from an asylum because he is considered no longer to be psychotic. Then we have a term called comorbidity, which is the presence of two or more conditions within the same period of time. You'll see this with a lot of conditions like depression and anxiety, or anorexia and depression. And as we move through mental disorders in this class, you'll see this come up a lot. The term incidence refers to the number of new cases of a disorder that appears in a population during a specific time period. The term prevalence means the total number of active cases, both old and new, that are present in a lifetime or in a population during a specific time period. Lifetime prevalence is the total population or total proportion of people in a specific population who have been affected by the disorder during their lives. So lifetime is different than just prevalence. So specific time period versus lifetime prevalence. Epidemiology is the scientific study of the frequency and distribution of disorders within a population. Epidemiologists assess whether the prevalence of a disorder is increasing or decreasing, where the disorder is most common, which populations and demographic profiles are at highest risk. And an organization in the United States that tracks a lot of this information is the CDC, or the Centers for Disease Control. And they will help provide information to the Health and Human Services administration to allocate funds and resources. So, for example, diabetes, which affects a lot of different populations, but specifically African Americans, can therefore allocate funds to specifically target African American populations in their marketing information to get out the word about how to treat and prevent diabetes. So, how are mental disorders defined? Some define it as behavior that deviates from the norm. And the norm are determined by culture and society. So what's normal in the United States might not be normal in another country. And that's very important to keep in mind. So the norms that are experienced within a country are very country specific. And you can draw that down as well, because then you have norms that are specific to specific ages, races, genders, different cultures within a larger society. So if you look at the United States, we have a melting pot of different cultures. You have Italians, you have Irish, you have Germans, you have West Africans, you have East Africans, you have South Africans, you have people from the Middle East, you have people from South America, you have people who have come over from Africa and they don't even know where they came from. So, you have all of these different cultures that have come in and their norms are all different. So what we have to keep in mind is that a norm is going to vary significantly by culture and society. So, for example, if you're in New York City, the fact that somebody might be gay or homosexual is no big deal. But if you go to a little tiny town in Kansas, that's going to be a big deal. Other people might define a mental disorder as something distinct from a physical disorder. However, there is an undeniable connection between our minds and our bodies. And if you think about when you are upset or anxious or depressed and how you feel sick to your stomach, or you have a headache, or you're just tired, you feel the same kind of physical depression as you feel an emotional depression. Or when you're very anxious about something, you have those butterflies in your stomach. So, a lot of doctors understand and researchers understand that there's that connection between the mind and the body. The most popular definition is that the disorder produces clinically significant distress or impairment in social, occupational, or other important areas of functioning. And this is from the Diagnostic and Statistic Manual of Mental Disorders, otherwise known as the DSM. And we'll talk about the DSM in more detail later. A mental disorder is therefore defined in terms of a harmful dysfunction. We can be depressed because our cat died, or we can be anxious because we have to give a speech, and once, the speech is over, we're no longer anxious. Or once we get a new puppy or a new kitten, we may not feel as sad. So it's not really harmful and it's not dysfunctional. Whereas somebody who suffers from long-term depression may find that it impacts every aspect of their life, leading to a harmful dysfunction. Another significant term in mental health policy is severe and persistent mental illness, and this refers to the trajectory of the illness, not the diagnosis. And the trajectory is the entire trip, so to speak, of the illness, the length. This includes serious acute episodes, acute being severe, psychiatric comorbidities, and as I mentioned before, that's defined as the simultaneous presence of two chronic diseases or conditions in a patient, and continuing residual disability, and high levels of medical and psychosocial needs. These folks have a lot of needs that have to be served by the behavioral health community. Also, we have to keep in mind that abnormal does not mean that a condition is rare. We like to think of mental disorders as being rare, and that's absolutely not true. Rare does not define something as a psychopathology. So, somebody who is born with 6 fingers might be rare. Somebody who suffers from depression is not rare. Depression, which is a mood disorder, affects 20 to 25% of Americans. That's 1 in 5 or 1 in 4 over the age of 18 in any given year. Only 50% of all Americans who experience an episode of major depression actually receive treatment. And we're going to talk about this in a lot more detail as we move through the class. And part of this is a cultural issue because especially men have been taught to be self-sufficient. And because men have been taught to be self-sufficient, when they're feeling blue, when they're feeling depressed, when they're feeling anxious, they have been internalized as a cultural norm to get over it, to man up. And so they don't seek treatment. And in a few minutes, we're going to learn what happens to a lot of men. 80 to 90% of adolescents that seek treatment for depression are successfully treated. That is extremely significant because we have a lot of young people who are very unhappy. They're having, problems in their lives, and if we can get them into treatment, they will overcome their issues. In 2002, it was estimated that the cost of mental health care, lost earnings, and disability payments in the United States was approximately $300 billion. And that was almost 14 years ago. So imagine how much it is today. Finally, on this slide, I want to just identify the difference between the words troubles and issues. Troubles are personal and private problems. So, for example, if you find out your 15-year-old daughter is pregnant. On the other hand, issues are problems that impact society as a whole and need public policy changes to address and manage them. In this case, mental health is the issue. So let's return to the concept of culture. All mental disorders are shaped to some extent by cultural factors, as we mentioned before. But no mental disorders are entirely due to cultural or social factors. Psychotic disorders are less influenced by culture than non-psychotic disorders. So, if you are schizophrenic, which is a psychotic disorder, a psychotic disorder is less influenced than being depressed or having anorexia. So if you're schizophrenic in the United States, you're schizophrenic in China, you're schizophrenic in South Africa, you're schizophrenic no matter what. It's not shaped by the culture. The symptoms of certain disorders are more likely to vary across cultures than the disorders themselves. So, in terms of culture and psychopathology, the example I wanted to share with you is the idea of bulimia, which is the fact of people who binge eat a ton of food and then they vomit it up. 90% of bulimic patients are women, and in the United States, the incidence is higher among women in college than women who are working. Bulimia is also a Western disorder primarily seen in the United States and Canada and is rare in other parts of the world. Bulimia is also more prevalent among younger women than older women. And this indicates that cultural values about our appearance play a big role in establishing risk for developing this disorder. So think about it. You are a woman or a young girl in a country like India where there may be food shortages, and you come to the United States and you meet someone who is bulimic, and you find out that they will eat 5,000 calories and then vomit it all up. And you're thinking, as someone who comes from a country where food shortages are average, how can they do this? You value every kernel of rice, every piece of chicken you can get your hands on, and these other folks are vomiting up food. So it's in many ways a cultural issue that these other cultures can't even imagine. So moving on, let's talk about the DSM-5. And the DSM-5 is the Diagnostic Statistical Manual of Mental Health Disorders, the DSM. It is a classification of disorders with associated criteria designed to facilitate more reliable diagnoses of these disorders. So basically, this is a encyclopedia or a dictionary of mental disorders. It is number 5 because it is the 5th edition. In 2013, it was revised by a large group of doctors and therapists and researchers to ascertain the best ways to diagnose and collect statistics on mental health issues. The DSM-5, as I mentioned, is also a tool for collecting public health statistics on mental health disorders, morbidity, and mortality rates. It is organized in sequence with the developmental lifespan. This organization is evident in every chapter and within individual diagnostic categories, with disorders typically diagnosed in childhood, detailed first, followed by those in adolescence, adulthood, and later life. So, in the book itself, the categories start with neurodevelopmental disorders, schizophrenia, bipolar, depressive, anxiety, obsessive-compulsive, trauma or stressor-related disorders, dissociative disorders, somatic symptom disorders, feeding and eating disorders, elimination disorders, sleep-wake disorders, sexual dysfunctions, gender dysphoria, disruptive impulse control and conduct disorders, substance use and addictive disorders, neurocognitive disorders, personality disorders, paraphilic disorders, and other disorders. And we're going to cover the vast majority of these in this class. So, one of the major consequences of a mental disorder is suicide. In 2014, 42,773 deaths by suicide in the United States, which is the 10th leading cause of death in the United States. Based on information from the CDC, it is estimated that over 38,000 of these suicides were related to mental disorder. 38,000 out of 43,000. That's a huge proportion. Every day, 105 Americans commit suicide. So who are most at risk for this? Men. And as I mentioned, culturally, men in this country have not been given permission to express when they are not feeling right inside. Adolescents, teenagers, and again, teenagers, they have all kinds of mental issues, not because they have any particular mental health disorder. It's because during their adolescence, they're having changes, extreme changes to the brain, especially to the frontal lobe and the prefrontal cortex that influences their abilities to make good choices, their impulse control, their ability to control the choices they make in terms of risk-taking behaviors. Whites and Caucasians and Native Americans. These statistics come from the CDC, or the Center for Disease Control. 250,000 people a year are suicide survivors. 1 in 25 suicide attempts is successful. 79% of quote-unquote successful U.S. suicides are men. Women tend to have more suicidal thoughts, but when they try to kill themselves, they use poison or they try to overdose, which has a lower rate of working. So they're not as successful. Women are most likely going to try and kill themselves between the ages of 45 and 54, which also happens to coincide with that empty nest syndrome when their kids are growing up and moving out, or postmenopausal time when they are feeling less, when their hormones are kind of having a party without them. So there's a lot going on emotionally for women. Men tend to use guns, which tend to be way more effective in terms of committing suicide. And of course, when you're using a gun, there's less chances that you are going to fail. Now, interestingly, women oftentimes use poison or pills because they don't want to leave a mess. Whereas men, that's not something that they're necessarily concerned with, because it's not an issue for them about who's going to clean up. Men are more likely to kill themselves after the age of 75 because they're usually widowed or divorced and they don't want to live life alone. So a lot of times these men will just take out the gun and eat the gun or put it to their head because they don't want to continue on. After somebody commits suicide, a psychological autopsy is done. And this includes hospital records and interviews with the decedent's friends and family. These are conducted to determine if there was a specific reason why the person committed suicide. And often there is a high incidence of mental disorders, especially depression. And keep in mind that at any given time, 20 to 25% of the population suffers from depression, and only 50% of people get any kind of treatment. So you're talking about, 50 million people in this country walking around without treatment for depression. So it is a big deal, and we have to, as people who care about others, be really vigilant and try and help others. Can suicide numbers be reduced? Absolutely. It is estimated that 50 to 75% of suicides could be prevented if depression and mental disorders were managed or addressed more effectively. 75% of suicide victims had visited their primary care physician in the 12 months prior to their suicide. 33% of suicide victims had contact with a mental health specialist in the 12 months prior to their suicide. That means that 1 in 3 people who commit suicide had seen a mental health specialist in the year before they killed themselves. And the intervention did not provide any mitigating factors for that person. So why not? And we're going to talk about these things in this class. Research demonstrates that the ER is the best first intervention point. Post-ER visits, these individuals are 6 times more likely than the average person to kill themselves. So, you have to grab them as soon as they're in that ER, when they've overdosed or they've tried to kill themselves that first time. The World Health Organization has conducted research that demonstrates that a 10-part follow-up post-ER visit will reduce the chances of individual committing suicide by 1,100%. And what that means is that when a person comes to the ER, they've tried to kill themselves, they're put in a 72-hour hold, they're eventually released, Then what's required is a behavioral health specialist doing at least 10 post follow-up visits to ensure that person is staying on their meds, getting the help they need. That's going to mitigate that person's likelihood of killing themselves because there's somebody who cares and following up. And that's a tremendous intervention for these folks. In a study that examined mortality among persons served by public mental health services in 8 states, from 1997 to 2000, clients experienced 13 to 30 years premature loss of life. On average, those with a mental disorder will die 8 years earlier than those without a mental disorder. Eating disorders have the highest mortality rate of any mental illness. 13.1% of people with eating disorders will die. So we see somebody who has anorexia or bulimia and we think they're spoiled little rich girls, but the reality is they have a higher chance of dying than somebody who is schizophrenic. So, these disorders are serious and they need as many interventions as possible. Other issues for those living with mental disorders, in addition to suicide, there is socioeconomic disadvantages. A lot of these people live in poverty. They have low educational attainment. They're less likely to be employed, or if they are employed, they're underemployed. They have poor impulse control, and they often have substance use problems. A lot of men, again, because they've been taught that if you have a problem, you handle it yourself. They self-medicate using drugs and alcohol because that's more socially acceptable than admitting that you go to a psychiatrist to medications. So let's talk about how some of these issues start in childhood. Antisocial behavior during childhood often results in difficulties as adults. And we see these behaviors in our kids, and one or two of these behaviors absolutely normal. But when you see a preponderance and that they are consistent and overwhelming, that's when you have to get your kids to a professional, get them into counseling, get them help. So when you see resistance to authority, now, first of all, show me a teenager who's not resistant to authority, and I'll show you a teenager who is already perfect at lying. But, it's normal, but taken with everything else. Delinquency, truancy, meaning they're committing petty crimes, they're not going to school, they have excessive drinking and drug use, they're engaging in premature sexual behavior, they have low academic achievement, they have poor reading skills. What ends up happening is their adult behaviors will then include they can't keep a job, they can't get a job, they have legal problems, they tend to abuse drugs and alcohol, leading ultimately to an early death. Long-term studies demonstrate that behavioral problems are more significant than emotional problems in terms of childhood's impact on adulthood. So a kid who might have some depression as a young person, that can be overcome and treated, but the behavioral problems need much more intervention. Conduct disorders have a wide range of negative outcomes, including, as I've mentioned, lower educational attainment, lower earnings, a higher risk of teenage parenthood, less likely to participate in the quote-unquote real economy, and legal problems. Finally, behavior and poverty are not connected. A lot of people like to draw a connection that poor people are bound and determined to have problems with the legal system, and that's just not true. If you live in a poor working class environment, that does not lead to having behavioral issues. We're all bad teenagers. We all get away with stuff. We all do bad things because we have poor impulse control. We are making bad decisions. We're teenagers. That's what we're doing. But there's a difference between being an average teenager and being a teenager who has a conduct disorder. So even if a child lives in a home with domestic violence, that can be overcome. A child's maladjustment has been correlated to numerous factors. So, the behavioral issues do come from, in fact, a lot of what happens in the home. Social deprivation. They don't have the opportunity to play with kids their own age. They don't have the opportunity to interact with other children. They come from a home where the parents have a very dysfunctional relationship. There's parental deviance. Mom is turning tricks in the bedroom while the kids are watching TV. Or dad is smoking crack in front of the kids. Child abuse, sexual and physical abuse, and lack of parental supervision. If mom and dad are not in the house very often and the kids are running wild, that's pretty much an open check to do whatever you want. The key, and this is the important thing to take away from this, is that health policy and mental health workers, behavioral health workers, can provide effective interventions to help children, young adults, teenagers, and older adults overcome all of these issues with the proper interventions. And that's what this class is really going to focus on. So, if you have any questions, feel free to text or email me. Otherwise, have a lovely day. And if you have any issues, please see a therapist. Thank you.